Hello everyone and welcome. Thank you for joining us today for UNRISD's first ever webinar on the socialprotection.org platform. We're very excited for this opportunity to share our work with you and to expand our seminar series to a virtual audience. My name is Kelly Stutter and I'm a research analyst with the Social Policy and Development Program here at UNRISD, and I'll be moderating our event today. For those of you who may not be familiar, UNRISD, the United Nations Research Institute for Social Development, is an autonomous institute within the UN system that carries out research and policy analysis on the social dimensions of development. Through our work, we aim to ensure that social inclusion, equity, and justice are central to development thinking, policy, and practice. Today's webinar is an extension of the UNRISD seminar series, which provides a space for conversation around the issues of relevance to social development research and policy. Through this series, UNRISD seeks to highlight the work of both new and established thinkers in the field of social development, to present the findings of our research to a wide audience, and to contribute to improving the quality of development debates. We invite you to sign up for our mailing list to learn more about these events from UNRISD, which you can do at unrisd.org, and we also invite you to follow us on social media to hear about our latest news and information. Today's webinar will present the findings of the recent UNRISD research project towards universal social security in emerging economies, with particular focus on the national level experiences with the universalization of healthcare in Brazil, China, India, Indonesia, Russia, South Africa, Thailand, and Venezuela. In previous decades, the policies and practices associated with neoliberalism eroded the support for universal social provision, including healthcare. In a wave of pro-market reforms, many countries shifted their healthcare systems from public to private management, with serious impacts on coverage and equity. But not all countries followed this path, and the examples of those that went against the tide and promoted universalization in healthcare provide us with valuable insights on how to create more inclusive systems. This is in line with the objectives of the Sustainable Development Goals, and particularly with Goal 3, which seeks to ensure healthy lives and promote well-being for all at all ages. This is a timely discussion. As you will hear from our panelists, the path towards universal healthcare is not a straight line, but a process that involves progress and regress. We can see this today as the United States Senate votes on bills to roll back the progress made during the Obama administration, and in Brazil, where lawmakers voted to freeze all social spending, including on education and health, for the next 20 years. In this context, the objective of this webinar is to provide an overview of the experiences of the case study countries as they sought to universalize their health systems, as well as to provide a framework for understanding why outcomes have differed across countries, taking political, economic, and institutional factors into account. For today's webinar, our first three panelists will speak for 15 minutes each, followed by remarks from our discussant for about 10 minutes. First, Il-Chun Yi will present the overall picture of the findings of this research, with focus on the lessons that emerge and the challenges and opportunities that countries encounter as they seek to universalize their health systems. After which, we are very pleased to welcome Armando Ginegri Filho and William Shao, who will present the experiences of Brazil and China in greater detail. Finally, our discussant, Indrajit Roy, will place these discussions into a broader context. We will then open to a Q&A session to take questions from the audience. If you'd like to pose a question to any of our panelists, we invite you to do so through the questions function. And for those of you interested in more information about the topics presented today, I urge you to download the research and policy brief that complements this webinar, which is available for free on the UNRISD website and is also included as a handout for the webinar. We have also recently published an edited volume, which was the culmination of this research project, entitled Towards Universal Healthcare in Emerging Economies, Opportunities and Challenges, which presents the findings from this research. More information about the edited volume will be presented at the end of this webinar and is also available on unrisd.org. I would now like to turn over to Il-Chun Yi. Il-Chun is Senior Research Coordinator at UNRISD, where he coordinates the Social Policy and Development Program, as well as the Program on Social Dimensions of Sustainable Development. He specializes in issues of poverty, social policy, labor policy, and historical analyses of economic and social development processes. Il-Chun, the floor is yours.
Thank you, Kelly, for your kind introduction. I'm Il-Chun Yi, Senior Research Coordinator of UNRISD, and I think it's a wonderful opportunity for all of us to know more about the process of universalization in different countries, especially emerging economies. Today, I'm going to share with you the lessons we have drawn from the experience of various emerging economies to universalize healthcare. Although they are about emerging economies which have their own specific political, social, and economic conditions, I think we can get some insights for other developing countries which make an effort to universalize healthcare in their own context. Let me begin with a brief background of the UNRISD project, which is the basis of this webinar. Leaving no one behind and reaching the furthest first are one of the key principles framing the 2030 Agenda for Sustainable Development. SDG 3, ensure healthy lives and promote well-being for all at all ages. In particular, Target 3.8, which aims to achieve universal health coverage, shows how we can concretize this principle of leaving no one behind in health sector. The global principle of leaving no one behind and the target of universal health coverage, in a way, reflect a widely shared view on the insufficiency, inefficiency, and unsustainability of selected and targeted approach on the one hand, and on the other hand, a shift in national discourse and practice that is bringing universalism to the fore. UNRISD research project entitled Moving Towards Universal Social Security in Emerging Economies was designed to draw lessons on institutions, processes, and actors constituting the process of moving towards universal health care in emerging economies for policymakers, advocates, and others seeking to expand and universalize healthcare. I would like to highlight two notable features of this project first. Firstly, it aims at drawing lessons from those countries which are currently undertaking universalization of healthcare. Since the 1970s, when global consensus on basic universal healthcare was formed, many developing countries have been looking at the experience of the global north, the advanced welfare states, to draw the lessons on universalization of healthcare. The global and national context of politics, economy, society of these countries when they built their universal healthcare systems were very different from those of developing countries now, and many policymakers of developing countries had to scratch their heads because of these contextual differences. This project, UNRISD project, is looking at the South, which have relatively similar conditions to those of developing countries compared to those of advanced welfare states which had built basic institutions for a long time. Second unique feature is this project, closely looking at the health sector, also paid a special attention to other sectors and factors outside health sector to explain the political economy and interactions between health sector and other sectors' development processes. In a sense, it tried to show how all policies, institutions, and actors contribute to health sector development and how health sector development affects the other policies, institutions, and actors. In addition to the methodologies and approaches of all those individual chapters in the book, these unique features of the project must have contributed to making the key lessons we draw from the research very interesting to both academics and policymakers. I think we have a slide, yes. UNRISD research, no, the first slide, please. Yes. UNRISD research on these emerging economies offers a lot of interesting facts and policy messages, but I'm going to focus on the lessons, on the factors enabling universalization. If you need to know more, as Kelly mentioned, we recently published a book, so I strongly recommend you to read that book entitled Toward Universal Healthcare in Emerging Economies. First factor to facilitate universalization of healthcare is empowered civil society and its cooperative relations with government. This is a bit different experience from that of many advanced welfare states, where the political coalition between trade unions and the government was the key driver of welfare expansion, particularly in health sector. As we can see in the cases of Thailand and Brazil, empowered civil society and its cooperation with the government were the key factors to move universal healthcare policies up the policy agenda and to determine whether the momentum of healthcare system reform can be kept or not. Second lesson we can draw from the experience of emerging economies is that fiscal space can be created not only by economic growth, but also by political will, institutional capacity, and political support for reform. This lesson is questioning our conventional wisdom that lack of resource is a key obstacle to universal health care. It also shows that even without enough financial resource, it is possible to make a significant move towards universalization when there is a set of conditions such as strong political will, highly developed institutional capacity, and a wider support for reform. Thai case is a good example for this, and Venezuelan case shows how the lack of institutional capacity and broader political support affects the sustainability of healthcare reform. Thirdly, the research shows the importance of democratic mechanisms to build consensus between different interest groups and maintain reform momentum. Universalism or universal health care is very much a polysemic concept and always subject to contestation over how to interpret and implement it. Effective and efficient democratic mechanisms to reduce the transaction cost of conflicting views on the universal health care is essential to implement smoothly the policies to facilitate universalization of healthcare. Relatively long process of healthcare reform in South Africa can be partly related to the lack of effective and efficient democratic mechanism. Next slide, please. Fourth, the healthcare reform in the 21st century has an additional challenge compared to those advanced welfare states had in their own past. That is the institutionalized resistance in and from the private sector. It reflects how significant the neoliberal reform in the health sector has been over the past decades. Although they are in different forms and with different degrees, this kind of resistance in and from private sector can be found in every case of our research. Societies moving towards universal health care should have a strategy to address the resistance in and from private sector. Fifth, policy coherence between different levels of government and across the sectors is also an important factor to enable universalizing healthcare. Decentralization has been undertaken in different forms and with different degrees in many countries, and these countries have to come up with nationally specific strategies to enhance policy coherence between different levels of government. And there must be a strategy to deal with unevenness in terms of welfare expansion, which I hope our discussant, Indrajit, will talk about in more details when he talks about Indian case. Six, the UNRISD research reaffirms the importance of tax-financed healthcare system. It is particularly important given the high share of unemployed persons and informal workers. Next slide, please. By nature, all these lessons I just talked about are dynamic because, first, they are lessons reflecting only a certain period, that is the period of achievement or expansion of coverage towards universal health coverage. And second, those countries were researched are still in an ongoing process of healthcare reform. For those countries which have already achieved nominally universal coverage, must deal with challenges associated with enhancing accessibility, appropriateness of quality, and redistributive impacts. However, developing countries which just embarked this journey towards universal healthcare can learn many lessons from these countries' experience. As a last point of my presentation, I'd like to highlight again, universal healthcare coverage is not just one target of the 2030 Agenda for Sustainable Development. Achieving universal social provision is integral to the agenda's central pledge to leave no one behind, and achieving universal coverage for healthcare is just one step towards realizing this ambitious vision of truly universal social provision, which includes all and leaves no one behind. I hope next presenters and discussants can talk about more lessons and findings which can help policymakers to successfully take a step forward for universalism in health sector and beyond. I think I will stop here and thank you for your attention. Over to you, Kelly.
Great, thank you very much, Il-Chung. Next, we're going to turn to a more in-depth look at the cases of Brazil and China. We will begin with Armando Ginegri Filho, who will present the case of Brazil. Armando is a medical doctor practicing in Porto Alegre, Brazil, and is a member of the People's Health Movement, Executive Committee Coordinator of the World Social Forum on Health, former President of the International Society for Equity in Health, and former coordinator of the Latin American Association of Social Medicine. Armando, please go ahead.
Thank you, Kelly. Well, first of all, I'd like to say thank you to all of you that are organizing this session, and to thank you, Il-Chung, by the very important work to edit all these research findings and different approaches. And I'd like very much to introduce myself. As Kelly said, I am a medical doctor, responsible of the Executive Committee of the World Social Forum Health and Social Security. That's a branch, a thematic branch of the World Social Forum, and member of different social movements around the right to health and social security. And I will talk to you about two main questions and around the research project that was developed. First of all, I'd like to introduce a general view about this work, and around those general remarks, I'd like to rescue a little bit the origin of this initiative and how it was developed in the last few years. Next, please. Next slide. Well, this project was the product of an initiative or the World Social Forum primarily, when we decided to organize a first World Conference on the development of universal social security systems. This decision was adopted in the World Social Forum in Nairobi in 2007, and finally the conference was organized at the end of the year 2010 in Brasilia, the capital of Brazil. We achieved to mobilize more than 100 countries with government and non-government delegations that discussed about the alternative of universal social security systems instead of the dominant proposals of fragmented and insurance-based systems that were promoted and are promoted by the international agencies. The fact that this conference was organized in Brazil permitted to make a kind of balance of the advancements and difficulties, challenges of the national universal health systems in Brazil, and to enhance the dialogue with the other components of our social security system. Because in our 1988 federal constitution, we established a chapter of social security and health rights. And in this chapter, we established the sense of universalism that must be adopted in all components of social security. So in 2010, we had the opportunity to present the advancements of the Brazilian process, but at the same time, we challenged other countries to think about the institution of national health systems and national social security systems in order to protect populations against the excesses and the damage that are provoked by the neoliberal policies around the world. In this sense and in this context, at the conference established the possibility to think about an alternative. And the next challenge would be to think how to make it, how to introduce universal social security systems, and within that the health systems, in countries where the development of the institutions were historically organized to achieve other kind of profile, a profile with a lot of social exclusions and with a lot of material limitations to make rights something that could be really enjoyed by all citizens. So in this sense, the initiative of this project of research that would compare with the dialogue between the different experiences of emerging economies that could look for full universalization of social security was engaged. So we engaged this project in 2012 through the Laboratory of Innovations in Health Policy and Systems of the Heart Hospital, Hospital do Coração in São Paulo, Brazil, using resources linked with the national program of the institutional strengthening of the unified health systems in Brazil. So we contacted UNRISD through our friend Il-Chong, and we accorded to make an effort combining the expertises of different researchers around the world to make 8 case studies of countries with the different kinds of approach to universal health and social protection systems. And the product of that is the book that was mentioned by Kelly and Il-Chong, and that tried to introduce new concepts and methods to analyze the progress and the transition efforts to achieve universal systems. So I invite you very much to go through this book and to see the different dimensions and different strategies that could be used to achieve a full universal system of social security or social protections in our countries. And following that, next slide please, I'd like to comment that there are some general characteristics that are very much challenging to our effort to universal systems. The first one is that we need to establish this debate as an alternative and to make a deeper reflection about the ways we can deal with the aspects that Il-Chong highlighted previously. Next slide, please. So, since we began our research effort looking for the broad field of social protections or social security, we try to connect the debate about the health system with the protection of work, pensions and retirements, social assistance, and so considering as an extension of this debate other dimensions of rights that could contribute to social security, including, in this case, education, housing, safety, energy, etc. Finally, due to the limitations of time and the limitations of expertise we could manage in this stage of our work, we focus mostly on the health protection, so in the health systems development. But we cannot forget, and Il-Chong highlighted that as well, that we need to connect the struggle for health with the other components of social security. Because in general, the struggle for health is not considered a high politics question, and it's necessary to link the health protection with the other protections, mostly the work and pension system, to make it much more strong as argument for political decision and political development of the systems. Next slide, please. One thing that is very important when we review the history of the social security systems or social protection systems in the world is the fact that the countries that are more successful in this were adopted their policies in a context of crisis and the need to protect populations against poverty, against the unemployment, against the general economical crisis, and so on. What means that the fact that we don't have immediate resource to apply for universalization of our systems is not something that must be used as an argument to eliminate the universalistic approach. In fact, if you consider the general crisis we have now, it's a perfect moment to understand and to apply the principles of universal systems in order to protect populations and to generate conditions for a broader development where all kinds of protections could be achieved. So in this sense, we are talking about a political decision matter. It's not an economical reasoning decision. It's a political decision that will engage values and senses of the public policies and social policies to protect people in hard times and to generate a different kind of development, where development could be understood as a multidimensional development, where the main question is to oblige economic rules to support this welfare of the populations. Thank you. Next slide, please. Next slide. In order to go ahead with this intention to introduce the universalism as a main aspect of our social and development agenda, we need to face three hegemonic narratives that are dominating the debates in the society and are provoking a very conservative approach to universalism and egalitarianism in our societies. The first narrative is the natural proportionality that is very much internalized in our cultural perspectives, considering that the natural existence of poor and rich, and considering that the aim of a good public policy is to provide equal opportunities, but not necessarily egalitarian perspective of society. This is very strong. It was spread in our occidental societies and now globally as a kind of globalism of thinking around the idea of society behavior and society understanding of nation's life. And it's necessary to oppose that with the perspective that there is no natural proportionality. What is existing is a social and political reality that was built around the idea of highly concentration of richness and a high difficulty to redistribute richness according to the rules of free market. So this is a big challenge to us to go through that and to change the perspective of society around it. The second narrative that is very challenging is the meritocratic perspective, where only the formal workers would be subjects of social security, and the difficulty to introduce a non-contributive perspective of social security, where the social and economical rights and the whole rights would be part of a kind of universal citizenship status, where everybody will be protected since they are members of a society. And the richness produced globally or collectively by this society will be the source to finance this universal protection. This narrative that restrains to the formal workers, the social security schemes is very much compromising the way we can go through much more justice, fiscal justice, or tribute justice, in order to capture the resources that are produced by richness accumulation and the way we can redistribute that. So it is in the aim of the debate of the nature of the social protection systems or social security systems we are looking for. The third narrative that's a big challenge for us is the narrative of social policy as poverty reduction, because it eliminates the complexity of the social policy and focus targeting poor populations as the aim of social policy. And it established a kind of division in society where the middle classes are not interested in social policy, since it's are policies for poverty reduction and not for the general welfare of population. So this is something that is very strong as a kind of general thinking about social policy, and is reducing the debate, the political debate about social protection as a full element of a society. So in this context, we need to consider the fairness of the tax systems and the way we can redistribute richness in a combination with universal social and public services that could be of use of all social classes in society. I think this is the historical experience of the Nordic countries, and this is a very strong reference in terms of capitalist context, and must be studied and understood in their real power. Next, please. Finally, it's essential to spread the understanding of the political economy of the universalism to go ahead through transitional process to universal, comprehensive, and egalitarian systems. It is very important that in the creation process of the systems, we establish the aim, the ambition to be universal. And in this sense, the nature of this creation myth will be definitive to keep the strategy, to keep the direction of the process, in order to avoid the introduction of models that will finally fragment or break the nature of universal and comprehensive systems. We are very much interested to promote the read and criticism about the book that was the product of the research, and we are very much interested to provoke this political reflection and action around the subject of universal social security systems, mainly in this case the health systems. And as a continuity of this effort, we are very much interested to develop partnerships that could go deeper in the reality of the countries in different regions, and to use the regional integration process as an opportunity to enhance these kind of debates. Thank you. Next slide, please. I'd like to comment briefly and to finish some aspects, apply the aspects of the Brazilian experience. As you know, Brazil adopted universal social security systems with the new federal constitution of 1988. In this particular chapter of social security and health system was defined as universal, comprehensive, and egalitarian. And with this orientation, all efforts that are made from since then are oriented to implement this very complex system in a very big country. We are the 5th country in territory and the 5th country in population in the world, and a country that was built over a very unequal social structures since we have till 1888 a slavery system in Brazil, and since then we have many difficulties to change our unequal social structures. So when we adopt a perspective of universal approach to social security and health, we were breaking many historical traditions in the country and promoting a transformation of a big and complex systems in terms of economic and social organization. In this perspective, what was adopted since then is a very complex design of new agreements between public and private interests, and the way to establish the system in all territories of the country, trying to provide a full care for health in every population and space. Next, please. Next, okay. We already achieved 9% of our GDP as health expenditure, but only 45% of that is linked with the public expenditures. It means that 55% is related with private sector, with private expenditure, and mostly linked with private insurances and out-of-pocket expenditures. But this is a very important lack of equilibrium in terms of how many people is protected by the public system. That means all population, because it's a citizenship right. 206 million people can use the system, and 158 million are exclusive users of the public system. They are not consumers of private health systems. It means that there are around 50 million people that are very much protected because they have the benefits of private insurances at the same time that they can use very selectively the high-cost services of the public systems. It was established like that because when we adopted the creation of the universal health systems in 1988, we negotiated the persistence of special health protection schemes inside this broader concept of health system, because it was necessary to have the support of the middle classes and some very protected workers sectors in order to make it politically possible to adopt the universal system. But since then, since 29 years ago, we are facing this double phase of the system where we have increasing expenditure on private sector and the problems to finance the public or state-owned structures to engage the national health system. So it's something that's a very important tension. It's part of our complex development, but probably is one aspect that will be very present in other countries, since we need to make political agreements to make possible universal systems. Next, please. So despite all constraints and ideological struggles that we are facing in the country, we have now a very big health system that offers a full range of services, from primary health care structures disseminated in the country to very high specialized treatments as organ transplantations or special cancer treatments. So all this is covered by our universal health system. But of course, the scarcity of resource is provoking a very strong problems in terms of access and even in results of the system. And this continuous struggle for resources that could establish an equilibrium between social needs and offer, and at the same time, the way the system, the economical order is supporting the increase of the private sector is something that we cannot ignore. I mean, at the same time that we are establishing all municipalities of the country and we are providing a very important access to population, we are a system that is still in process of stabilization. So we are not stable as a system. We are looking for our equilibrium point, and probably is the task for the next 30 years. I mean, we need to open our mind for a bigger historical period to integrate our efforts in a deeper and deeper understanding of this complexity. And as a federative republic, we have a permanent negotiation process among the different actors. the national government.
If I could just come in quickly, in the interest of time, we'll have to ask you to just make one or two concluding remarks so that we can move on to the remaining presentations. And perhaps if there are questions specific to Brazil, they can come up in the Q&A section.
So, are you finished now? Next slide, please. Next slide, please. So, with all these advances and difficulties, we can consider that the universal health system in Brazil an example of a possibility of a universal system as alternative to the hegemony we have now. And the dialogue between India, China, Russia, Brazil, South Africa, within the framework of the BRICS is a proof of this possibility to engage a larger process of reflection and action. And the engagement of research efforts on policy making and implementation is maybe one of the main aspects of the collaborative efforts that we could develop. And this, in this sense, is necessary to use opportunities as this research project that was developed with UNRISD to reinforce the knowledge about the process of transition to universal systems and the way we can learn with each other how to make possible to challenge the different obstacles we need to make. Thank you very much.
Great. Thank you very much, Armando. It's a very interesting presentation. And now we are extremely pleased to introduce William Shao, who will present the case of China. Professor Shao is the K.T. Lee Research Professor of Economics in the Department of Health Policy and Management and the Department of Global Health and Population at Harvard University. And he is a leading global expert in universal health insurance, which he has studied for more than 40 years. Professor Shao, the floor is yours.
Thank you. It's a pleasure to join the webinar, and I'm going to describe to you and analyze the Chinese journey toward the universal health coverage. I advised the Chinese government for 33 years on universal health insurance and universal coverage, and I also work as an outsider to evaluate China's performance. Next slide, please. Let me begin by, next slide. Let me begin by just say our paper trying to analyze what made the universal health coverage possible in China. And we applied John Kingdom's theory that there has to be a stream of forces converge to make a major reform possible. And here's my slide showing the problem has to be well recognized and accepted by the whole society. The second, there's some policy alternative already been developed. Third is what Armando and also Yin-Chang has been talking about. The politics has to allow something to happen. But fourth is that there has to be a physical capacity because universal healthcare requires money to make it happen. Next slide. What is the problem that confronted China that made the whole thing possible? I would say SARS epidemic really showed China that Chinese healthcare system is weak and has many faults. And consequently, in 2003, Chinese government decided to really think how to make a major change to its health system. Next slide. As other speakers said earlier, what's important is a value system behind a policy. The value system here, as Yin-Chang said, is, does the society believe I don't want to leave anybody behind. Is everybody going to be treated at some basic level the same way in healthcare or in social protection? China, as an authoritarian state, but also with strong socialistic belief, embraced the universalism without much debate, other than debate within the Politburo and within the government, but not public debate. And China decided in 2009 to devote significant amount of new money to expand insurance coverage. But the problem is, with the limited resources, at that time Chinese economy was only having a per capita income of a little bit more than $2,400 per person. Do I try to cover everyone but with shallow benefit package, or cover only some people like the organized workers in the formal sector with rich benefits but leave other people out? China made a major decision that it will cover everyone, but initially with shallow benefit package. And then in this graph, it shows that China has to deal with other problems in the healthcare system, which Amanda did not actually elaborate. There are some fundamental problems in every country in its healthcare delivery system besides financing. And so China decided to deal with the drug problems, the provision of the preventive and primary care, and China did not know how to really reform the powerful public hospital system that employed 80%, 90% of the doctors. So China decided to pilot different reform efforts. Next slide, please. Let me then give you the results. China was able to expand the insurance coverage, shallow benefit package, very quickly to the whole nation, and now it reaches 96% of people are covered by health insurance. And then you can, on this graph, you notice starting in you don't need that much money if you cover only shallow minimum benefit package. But in 2007, China devoted more resources to expand the benefit package. Next slide. And now you see in this slide, China actually, the out-of-pocket payments had decreased from 60% to roughly 33%. And the insurance and government finance healthcare has increased from roughly 37% in 2001 to roughly 56%. And that's over a decade period. Then, next slide, please. What is the remaining problem? To expand, next slide, please. China actually have 3 insurance benefits for 3 different populations. One is for the rural residents, those are the farmers and the rural rural workers. One is employees in the formal sector, including civil servants. Another one is the urban residents who are not employed in the formal sector. Each one has a different benefit package, but the richest one, the workers in the formal sector has the richest benefit package, while other two have less. That's what this diagram tried to show. Next slides. And what it means is really there's no equal protection. But China at this moment, next slides please, is trying then to deal with, to equalize the three different benefit packages. However, next slides please. The greatest difficulty, so China tried to equalize the different benefit packages, but the greatest challenge is how do you, a nation, get reasonably good quality of care to everyone? China has 1.3 billion people and it's a large geographical territory. How do you get reasonable quality and affordable care down to every village, every town, every neighborhood in the city? People have different expectations that varies with their income. And how do you create a supply of services that meets people's expectation? That's a universal challenge right now throughout the world, in any country. And particularly then in China with such a large and diverse population. And meanwhile, Chinese healthcare system is riddled with inefficiency. Although China is only spending 5.6% of its GDP for healthcare as compared to Brazil, that's just, Amanda just said, they spend 9% GDP. We know China, at least 30% of the expenditure is wasted with over-prescription of drugs, over-testing of the people, and over-hospitalizing patients. That's because the delivery system was built on hospital-centered healthcare. Furthermore, that system turned the public hospital, which make up 85% of the hospital beds in China, it turned these public hospitals and doctors as profit-making practitioners and organizations. And that's what China is trying to address. So last slides, please. Now next slides. Let me say now what lessons learned. First, China with authoritarian state was able to achieve universal health insurance coverage very fast by any world standard. In less than a decade, China covered 96% of the people. However, universal insurance coverage does not mean equal, available, reasonable coverage of quality services. That, I think, is a major lesson, and China is still struggling with it. Second lesson China can teach the world is introduce insurance coverages easier than reform delivery systems, particularly correct the poor practitioners' behavior when they are pursuing profits. Once physicians and hospitals got accustomed to become profit-making entities, they explore patients. And it's very difficult to correct that mindset and the sense of purpose and the dedication of the practitioners and hospital directors. Third lesson China can teach the world is reasonable quality care are likely to require major alteration of payment, incentives, mechanisms in the whole system, reform the organization, improve the competency of the practitioners so they can earn the trust and confidence of the patients, establish information system, and so forth. So my last point is universal health care or universal health coverage most likely for most countries means a complex health system change. Just like if you're going to change, let's say, a socialistic central planning economic system to a market system, it requires a major shift. And that requires technical expertise, and as Amanda and Inchang said, you require long-term commitment to implement. So China right now has universal health insurance coverage, and the basic benefit package continue to expand as China gets richer. But to make sure everyone has reasonably good quality of care is a much bigger challenge, as well as make the system work efficiently. That's another big challenge. I want to thank you for this opportunity to share Chinese lessons for the world.
Great. Professor Shah, thank you very much for joining us today. We know you have to leave now, but I'd like to take this opportunity to thank you again for taking the time to participate in this event.
Right. It's my pleasure. Thank you.
Thank you. I would now like to invite our discussant, Indrajit Roy, to provide his comments. Indrajit is an ESRC Future Research Leader at Oxford University, where he studies the political ideas, identities, and practices of circular labor migrants in India. Indrajit, please go ahead.
Thanks, Kelly, and thanks, everybody. It's a delight, really, to be able to speak on this occasion. I think the significance of the findings that have been presented today go far beyond healthcare reforms in individual emerging economies. And what I want to do is to relate some of the discussions on urban health, on the universalizing healthcare to the expansion of social assistance that appears to be the opposite of the standard neoliberal model. And we can come back to that in questions later. But I think I want to start with a couple of points made in the book itself on universalism. And it's a very timely reminder, as some of the previous presenters have said, to us that universalism is, means several things. And universalism in social service provision may look very different from one context to another. And there are 6 dimensions that I want to quickly enumerate because I think they're a very useful way of thinking about the discussions that we've had so far. The first is entitlement, the legal relationship between the beneficiary and the social service or the benefit. The second is eligibility, the qualifying conditions for the beneficiaries. The third is access, the extent to which the beneficiaries can consume or use social services and benefits. The fourth is appropriateness, the extent to which benefits and services are provided. The fifth, distributive rules, how costs and benefits are distributed. And the sixth, the organizational principles or political values or value systems, if you will, around which the social policies are constructed and framed. Now, programs that are claimed to be universal may excel in some of these dimensions while failing in others. For example, a legal right to health care does not automatically mean that all people can access an appropriate health facility, or that the proper institutions are in place to provide affordable care. Alternatively, healthcare may be widely accessible, but public facilities may be underfunded. It is also possible that the health facilities are universal indeed, that all the funds, all the facilities are available, but the organizing principle, the political value, is not necessarily one of rights or of citizenship, but something else, something that is more driven by patronage. Okay, now, so this is about universal, the various ways in which one can think of universalism. As I said, I want to link this discussion and the discussion on universal healthcare with the expansion of social assistance more generally. And I think here it's good to bear in mind some figures that suggest that social assistance programs in the emerging markets are extensive. The 5 largest social assistance programs in the world, which are provided by China, India, and Brazil, together reach about 486 million people, which is almost the total population of Europe. Social assistance programs reach 54% of the population in Indonesia, 24% in India, 61% in South Africa, 25% in Brazil, 44% in Turkey, and 59% in Mexico. As a percentage of the total government spending, social assistance spending increased by about 142% in Brazil, 266% in Turkey, and 281% in Mexico between 2000 and 2010. These are World Bank figures. Not only is social assistance extensive, it is also decommodifying, contributing to 51% of the income of beneficiaries in Brazil and 45% in Mexico, contributing benefits of up to 70% of the minimum wage for households under the poverty line in Turkey, and covering and contributing more to poor people's total incomes than social insurance programs do in India and in Indonesia. The last 2 decades have seen a rise of these sorts of welfare regimes all over the world. And the programmatic element that has been at the heart of this transformation is what one might call the cash transfers. And that's the first kind of expansion of social assistance that I want to quickly refer to, with nominal conditions attached to them. Well, they're nominal in some and not so nominal in others. These programs are, of course, most commonly associated with Latin America, in particular the Oportunidades program in Mexico, followed by the Bolsa Familia in Brazil, both focusing principally on families with children. But what was once a Latin American phenomenon has gone global. A 2009 World Bank report traced the growth of cash transfer programs across scores of countries worldwide, noting that countries have been adopting or considering adopting CCTs at a prodigious rate. Hanlon, Barrientos, and David Hume have characterized this shift as a development revolution from the global south. The UK Department for International Development has noted that such programs are now estimated to reach between 0.75 and 1 billion people. Sorry, I think so that's the situation with the global sort of outreach. If I want to sort of pick up a few country cases, and I want to start with South Africa, move on to India, and perhaps talk a bit about Indonesia. In South Africa, we see the emergence of a very extensive set of state commitments to provide monthly cash payments to a wide variety of beneficiaries. Grants are paid to more than 16 million individuals, which is some 30% of the total population. Nearly 3 million South Africans aged 60 and above receive old age pensions, with another 11 million receiving child support grants. Now, these benefits are non-contributory, that is, they are not based on payments made previously by recipients and are paid directly from the state treasury. One research has pointed out that the South African old age pension as of 2010 amounted to 1.75 times the median per capita income. And so these reach a huge swath of the population, a figure that reaches about 60% in the predominantly poor and rural provinces of Eastern Cape and Limpopo. Now, this is in regard to the universal sort of, in regard to the social assistance situation more generally. But when you compare this with the health coverage in South Africa, and one of the contributors to the book reminds us, the health coverage is extremely patchy. Despite the fact that South Africa devotes 8.5% of its GDP to health, 84% of the population rely on the under-resourced public sector. Whereas in the private sector, the expenditure, per capita expenditure on health is equivalent to about 11,000 South African rand. In the public sector, this figure is as little as 2,000 rand. So you see a very, very different sort of situation with the social assistance sort of program and social assistance programs and the extent to which health sector coverage is indeed universalized. One sees a similar situation in India as well, where the combined public expenditure on health reached 1.04% of the GDP in 2011-12. This is far, far below the figures we have for Brazil, China, South Africa even, as well as for countries in some of India's neighbors, such as Nepal and Sri Lanka. According to the World Development Indicators, India has some 36 beds, India has some 9 hospital beds per 10,000 people compared to 36 hospital beds that China has. So that's significantly less. The severe shortage of public health infrastructure can be illustrated by the fact that the average population served per government hospital is 98,000. And the average population served per government hospital bed is 1,512. So it's a rather difficult sort of situation as far as health, universalizing of health is concerned. But you have this very patchy system coexisting with huge expansions in the realm of public works. And this is the second sort of social assistance program I wanted to draw your attention to. A major focus for rural development has been the productive absorption of the underemployed and so-called surplus labor by the provision of direct supplementary wage employment to the rural poor through public works. And here we have the Mahatma Gandhi National Rural Employment Guarantee Act, which represented a paradigm shift, as it were, towards fulfilling the long-standing demands of the Right to Food campaign and other labor movements in India. The act stipulated that any adult willing to undertake casual labor at the minimum wage would be entitled to employment on local public works within 15 days, subject to a limit of 100 days per household per year. As a result of this program, rural open market wages have risen from Indian rupees 65 in 2006-07 to Indian rupees 128 in 2012-13, partly because the wages provided under the program were much higher than the prevailing rural market wages. The program made work available locally, giving landless laborers the choice to work within the vicinity. I've been told that my 10 minutes are over, so I just want to quickly, sort of take the discussion from the South Africa and the India case to what it means for us in terms of understanding universalized healthcare, but also expanded social assistance program. And I think the point that we need to get from both of these cases, as well as the cases that have been discussed, is that despite the overarching neoliberal sort of discourses that one hears of or that one encounters, the fact is that governments across the global south, especially in the emerging markets, have been thinking of and implementing programs, social assistance programs that actually interrogate the standard neoliberal model and have brought us to think about not only new forms of social assistance, but also new forms of citizenship that underpin these social assistance programs. The book very nicely draws attention to the structural factors that are responsible for these expansions, the political factors that are responsible for these expansions, and the ideational conflicts that attend to these expansions. But obviously there's scope to nuance the explanations more, which we can discuss more in Q&A. Thank you very much.
Great, thank you very much. We really appreciate your comments, and just looking at some of the questions that have come in already, I think we'll be circling back to some of those themes as we move on. I want to take this opportunity to thank all of our panelists for their contributions, and we're now going to open up with some questions from our audience. Before we do so, I just want to take a brief moment to mention, as you noticed, Professor Shao had to leave, but thankfully we've been joined by Shufang Zhang, who has co-authored the Chinese case in the edited volume and in this research project with Dr. Shao. A brief introduction, Shufang currently works at the Global Fund to Fight AIDS, Tuberculosis, and Malaria, where she coordinates technical support to assist countries in intervention prioritization and resource allocation to maximize impact. She previously worked with UNRISD to coordinate the research project Migration and Health in China. So welcome, Shufang, and she'll be available to answer questions about the Chinese case and more broadly as well. So to kick off our Q&A session, I would like to start with a question that we actually received over email earlier this week. We were asked about community-based health insurance and whether it would be possible for communities to organize universal health insurance independent of higher levels of government. Il-Chung, perhaps you could comment on this and provide any examples that you might have, and then we can pass on to our other panelists.
Thank you, Kelly. I think this is a very interesting question because there is a kind of increasing demand from grassroots level to have more healthcare coverage independent of the government because of the incapacity or the weak capacity of the government to provide health service to their own people. And there is a very interesting case in South Africa. Rwanda case is very interesting in terms of its performance and in terms of their collaboration between villages and the government. Rwanda government promoted community-based health insurance very much actively, and the enrollment rate increased from 7% in 2003 to almost 90% in 2010. And there was a kind of very interesting dynamics between village level health insurance communities and the government and the private sector. So I think we have to pay attention to this, the term independently from the government, because if you don't have proactive intervention of the government, it's less likely to have a successful performance or implementation of community-based insurance, because they need supportive institutions and policies to promote the enrollment into community-based scheme and to get an access to private and public sectors provision of service. So I think it is possible to have successful case based on community-based insurance schemes, but at the center of the success is the active government's intervention and policies and collaborations between community-based insurance communities and government. I better stop here. Thank you.
Great, thank you, Il-Chung. Armando, did you want to comment on this one about community-based healthcare and health coverage?
It's a challenging question because, as Il-Chung said, sometimes we have the temptation to believe we can solve the health and other social needs of population through community insurance systems. The problem is the limit of that. I mean, the limit in terms of money, in terms of resource, and according to that, the limit of kind of service we can dispose from this kind of community insurance. So we can observe now that using this umbrella, this very large umbrella of the universal health coverage, we are promoting the different approach, the very fragmented insurance schemes that could cover different sizes of populations and create a kind of diversity of benefits. And I think the question that we need to observe is that the most powerful agent to redistribute richness and to establish protection in society is the state. If we adopted a very fragmented system where different communities can provide their own schemes, the different capacities of communities will establish a very different access to social protection. And by this way, we'll be crystallizing, we'll be establishing the unequal in society as a kind of rule. I mean, according to your research, you have your own capacity to solve your problems. And it will eliminate one of the fundamental questions in social security process, that is solidarity. So if I'm not able to be solidarian with people that I don't know, but they are part of the same society, the same citizenship agreement, you break any kind of solidarity perspective. So in this sense, social protection won't be able to redistribute richness. We will only establish rules that will keep the difference, the unequal difference, as a kind of permanent condition in society. So in this sense, I'm very much aware about these community schemes. And I would say that instead to create those fragmented answers, it's better to introduce a deeper reflection on political action to create wider and solidarity-based schemes and systems. And I think this is the main issue of our debate. Thank you.
Great. Thank you very much, Armando. Shufang, did you want to come in on this one as well?
Yes, I would like to echo Amdo's viewpoint. If it's all possible, I guess if we could avoid maybe not to building the community house insurance to start with, because in the longer term, the integration or the different segregation of different insurance schemes make it very difficult for the nation to trying to merge and trying to design a even insurance scheme for everybody else. Also, the community insurance scheme often are very small scale, and the risk pooling function are very limited. And but before we marching on to the universal health insurance schemes, many countries in history has started with community health insurance, and we've seen. I think there is benefit. It's a certain level of risk pooling. It's better than you have no insurance at all, but it also comes with its own limitations. For example, because it's small scale, the risk pooling function is limited. Often the benefit package would be also rather minimal. And if it's not very well managed, the potential fiduciary risk of this community insurance funds is in question. And then sometimes also perhaps quite hard to make this completely mandatory. Otherwise, you would be facing severe moral hazard, selection bias. Only the good risk or the people are really sick would like to be part of the community health insurance. So I would say in general, I would not be really favoring this. But in a situation if a country really has no immediate prospect to say a universal health insurance scheme could become available to meet the people's needs. I think the community could considering this, but I would caution a few things they have to think very well through. First of all, could they make this totally completely compulsory? And is that easy to implement? Otherwise, we already set for a deficit from the start. Second of all, would they be able to better quantify the premium levels each person would enroll in this scheme to pay for, and what would be the sustainable benefit packages they offer to the people. If the income level is low at a country level, and if the health product service are high, the benefit package would have to be very minimum. And the issue is what should be in that benefit packages might be some very important primary services, then again, the risk protection financially would be very limited for this limited benefit package. And then another important one, the last one, would be how the community health insurance scheme can best manage its funds. And since the group is small, that insurance scheme maybe have a limited negotiation power of setting or influencing the price to the providers, and how can they really manage this in a sustainable manner and hopefully potentially keep growing it, and also enlarging the benefit package if that's possible with income increase and with more people getting enrolled. Nevertheless, I think a country or the subnational national leaders should think about the longer term horizon. How does this building a broader protection of the scheme, and how that would eventually merge into a broader health insurance scheme to that provide universal access to the citizen of the country. I'll stop here.
Great. Thank you very much. Well, our next question, now turning to the questions that have come in from our live audience. We've received a question: most universal healthcare systems are limited to health protection. What are some of the feasible strategies to guarantee protection against the economic and social consequences of illness? I'll pass to Armando first to weigh in on this question.
Thank you, Kelly. I think it's a very substantial question, because most of the time we are talking about healthcare delivery, specifically in medical services or health service in general. And we are not linking the health right to health with the other connected rights in a systemic approach to the rights. So it's very hard to be able to achieve substantial results in health if we are not considering the social determination of health that's linked with other fields of the rights, as the right to housing, to work, and employment, and salaries, and access to education, justice, whatever. So in this sense, it's very much important to understand how to connect health in this first circle of social protections, no? And then in a bigger picture of the well-being in society. I mean, it's very hard to have a very limited approach to health systems, especially if you want to be universal, if you don't connect with the other rights systems, the interdependency, with the interdependency criteria. In this sense, social assistance, as it was mentioned by our commentaries, is very important, because it's something that will enlarge the protection to other dimensions, as economical safety and other aspects of social care, and then to complement in a very active way the universal health systems. I mean, there is no universal health system if you don't have universal social protection systems that could be able to engage the other dimensions of the well-being in society. So it's important not only as a concept of services, but of system or network of service, but it's important as well as a concept to look for or fight for the resources we need to sustain universal health systems and the universal social protection system. Because when we engage this broader perspective, we will be obliged to talk about work and the productivity and work, and the way this productivity will be absorbed by salary policies, and then the way to make a distributive process of richness in society, not only compensatory system as this conditional transfer of money, but a broader understanding about richness production and distribution, and then we can understand social protection as the most effective way to redistribute richness, even when we don't have economical growth. That's something very important. There are many economists saying that, and I think we need to consider this redistribution even in the absence of economical growth. Thank you.
Great, thank you very much, Armando. And I think it's a very well-received point that social protection is part of universal health coverage and health care across many dimensions. Our next question is going to be directed to Il-Chung, and it's specifically about financing universal health care. And our audience would like to know a bit more about the financing mechanisms. How do you mobilize the financial resources towards achieving universal health coverage and universal health care? And also our audience members asking for some more explanation about the Thai and Venezuelan cases that you mentioned in your presentation. So over to you, Il-Chung.
Thank you for your question. I mean, first of all, I will address the second part of this question about Thai and Venezuelan cases. Thai established their own universal healthcare system called 30 baht, which covers the kind of rest of people, the people who are not covered by the formal universal social health insurance. That 30 baht system was established just after the financial crisis when they were suffering from the lack of resources. And Venezuelan case is a bit kind of an opposite case to this because Hugo Chavez established kind of a expanded health coverage by in collaboration with Cuban doctors by using the resource from the mineral rents, oil rents. But that system couldn't be sustainable because of many reasons, but one of the reasons was he couldn't change the institutional structure and he couldn't mobilize wider political support for that system and regime. So what I'm saying, which is related to the first part of this question, is that we are not saying that we don't need resource to establish universal healthcare. We need resource, but I think that resource or fiscal space can be created by other factors such as strong political will, institutional reform or capacity, and a wider political support for healthcare reform. So when we are thinking about healthcare reform for achieving universal health coverage or universal health care in the context of developing countries, we have to think about various factors, and fiscal resource scarcity or the limitation of fiscal resource is not a major obstacle to achieving universal health care, because if you have other factors to create fiscal space, you can establish universal health care. And which resource? I think it depends on country's political economy. You know, in mineral rents, resourceful country, they can utilize those mineral rents, and if it is very much export dependent economy, I think they can utilize resources generated by exports. And if they are very much dependent upon domestic consumption, you can think about some taxes which can be generated from the domestic consumption and the circular economy, whatever. So it depends on individual countries' context, but the main message is that lack of resource is not a major obstacle to achieving universal health coverage or providing universal health care service to entire population.
Great, thank you very much, Il-Chung. Our next question, we received two questions around the theme of the engagement with the private sector, and I'll pose the first half to Shifang and the second half to Armando. The first half is a question about how we can talk about the mix between private actors and state provision within a universal healthcare system. Shifang, would you like to come in on that?
Yes, so I think it's multifaceted questions. If we step back and look at what is universal health coverage, first of all, it is about financial protection. It's not all about financial, but it's about the financial protection. In this situation, the key question is about financing. So it's not less about who provides the service, more about whether the financial needs that population would require can be met. So in this situation, we do hope and that country have a stable source of funding that support and cover the resources required for providers to deliver services to the people they serve. But universal health coverage, it is also about cost. If the cost is very high and it's very hard to contain. So I would say, depending on the debate, in countries, for instance, like China, we actually in the current round, since 2013, as Professor already mentioned, we encourage the healthy competitions between the private and public providers so we can improve the quality of the service delivery and potentially also lower down the cost. That in general also addresses the need of hopefully lower down the cost of the service provision and improve the quality. That is a very integral part of universal health coverage. Again, I think we can definitely achieve a very harmonious situation when both private and public providers are providing services and making sure for the private sectors, their price are properly reflecting to the payment incentive the government want to set up ways that they provide a good care and affordable cost, and so that these two can be tackled. And we do see there are occasions some countries fully provided publicly, that's fine, but they also have to address the quality and the cost containment issues. So in a nutshell, there is not a problem. And in some settings, we may be even encouraging the provisions of the both private and public sectors, because if people living in very far areas, it's oftentimes their first point of contact is the private clinics or pharmacists. That is not a part of the public system to provide them service.
Great, thank you very much, Shukang. Armando, I'll invite you to come in both on the question of the public-private mix and also a question we received about reducing resistance in and from the private sector, especially surrounding the high cost of doing business. Our audience member specifically points to the case of Zambia, where there's resistance from the health sector in issues such as maternity protection. So I'd like to welcome you to comment on this question.
Yes, thank you. Well, in the Brazilian experiences, when we adopted the universal approach to healthcare, we were obliged to engage private sector, for profit and for non-profit private sector, in order to enlarge our capacity to make healthcare provision. So we were obliged to face the fact that the state-owned facilities were not enough to sustain a universal healthcare system. So I think this reality will be, well, the reality for most of our global South countries. So we are obliged to consider the way we can manage the relationship with the private sector, mostly first of all with the non-profit sector and then with the profit sector. And we need to consider that health as a kind of a public good need to engage an approach that will reinforce the public perspective. And sometimes the state-owned facilities are not public in the sense that are not organized to make the best for the population that they are servers. So in this sense, the revolution we need to make is to establish the concept of public, not necessarily linked with the private or state-owned situation, but it's a kind of general engagement that will be established by public law that will permit to regulate private sector according to public interests. So in this sense, we need to understand that the complexity of the health sector obliges us to control the market dynamics through the defense of and the promotion of the public interests. Since we adopt a universal approach to right to health and the right to social protections, all kind of services that will be engaged on this kind of activity must be according to the public interests. It will demand specific laws, specific mechanisms for regulation, a lot of transparency, and the warranty made by the state that the warranty of the quality of service and results will be according to interests of the general population. In this sense, the way to make innovations or competitiveness between state-owned and non-state-owned facilities and services could be positive. but it is necessary to reinforce our capacity for public regulation and public control. What demands a lot of transparency with social participation, where the consumers, or the users, the citizenship, will be able to manifest their interests in the way the system must be organized, and will feedback continuously about the quality and the nature of the result. So I think this is the way to engage these private and public or state-owned facilities, building a stronger concept of public interest. Thank you.
Great, thank you very much, Armando and Shufang. Ilchang, I'm going to pass to you to come in with any final thoughts. We're reaching the end of our time here. We want to thank everyone for their excellent questions. Ilchang, anything you'd like to add?
Thank you. First of all, thank you very much for all the participants which are part of this project, and thank you very much for the participation of viewers to make questions and debates very rich for all of us. And the universalism or universalism in social service provision context is very much holistic concept, and it is subject to contestation, and it involves various levels of political struggles. It involves a discursive struggle about the meaning of universalism, and it involves implementational struggle over the means of implementation of universalization of healthcare, and it involves the struggle over resources, about how to allocate resources on which sector of social service provisions. So I think, given that universalization of social service has various levels of struggles, I think we need to know more about the different positions and different ideas and different interpretations of terminologies and concepts, and we have to establish our own strategies which can lead us to desirable situation of social service provision. So I think, I hope this kind of seminar can help you to think about more about the better strategies to achieve desirable state of social service provision in every country. That's what I thought when I observed the discussions among us and the questions from audience. Thank you very much.
Great. Thank you very much, Ilchang. I'd like to take this opportunity just one more time to extend a big thank you to our panelists today for their presentations, and to our audience members for joining around the world and providing excellent questions and reflections. Could I get the next slide, please? For those of you who'd like to learn more about this topic, we encourage you to both download the research and policy brief that complements this webinar, which is available for free on the UNRISD website, and is also a handout on this webinar, so you should see it on the right-hand side of your screen in the drop-down. We also encourage you to pick up and read the edited volume, which is the main output of this project, Towards Universal Healthcare in Emerging Economies, Opportunities and Challenges. There was some information on the previous slide, and there's some information on our website as well. The whole book and all the individual chapters are available for download from the publisher if you just want to look at one particular case study. For more information about UNRISD, you can always find on our website or sign up for our newsletter and follow us on social media. And the book has also just been released in Portuguese, so I'll pass to Armando to say a quick word about that.
Thank you, Kelly. Yes, I'd like only to inform and to the fact that we translated this original English written book in Portuguese. We launched the Portuguese version till the end of this year with a special introductory chapter trying to explore the context of this debate in South America and in the African countries that speak Portuguese. And in this sense, I'd like to thank you very much the effort of the team that worked in the research process and the translation team in Brazil. So we wish to to promote the use of this Portuguese version as soon as possible. Thank you.
Great, thank you very much. I'd just like to say to those of you who didn't have your questions answered, please do, if you'd like to reach out to us over email, we'd be happy to engage with you that way. This webinar has been recorded and will be available, the slides and the recording will be available on socialprotection.org. So just finally in closing, I'd like to thank our colleagues at socialprotection.org without whom this would not have been possible. So thank you everyone, and we'll sign off here.
Kelly, are you there?
Great.